So are you able to see that right now?
Yes.
Yeah, that's coming in okay?
Yeah.
Okay. I know that you did a little bit of an intro there. I caught kind of the tail end of that, but I'll do it here. So again, my name is Dr. Sasha Blaskovich. I'm the director of the Whiplash and Injury Clinic, and there's two locations. One is in Langley, BC, and then the other one is just across the border in Lyndon, Washington, which is where I'm coming to you from right now. And so there's my name, and there's two main websites, I guess, where anybody looking for more information after this can go to, and that would be the Whiplash, or sorry, www.whiplashclinic.com, and the other one is www.drblaskovich.com. And both websites have different information and relevant things for people dealing with injuries and specific injuries as it pertains to the head and neck. So without further ado, thanks for having me. The topic today, this was a little bit by consensus and a little bit by my own biased preference, is going to be a review of cervical spine bony anatomy and an overview of viewing the cervical spine using X-ray. And as some of the people there may know, or you might know, is that I use X-ray in my clinic, but it's not standard X-ray. It is a motion X-ray or video fluoroscopy, which I will show at the very end of this presentation as a teaser, because there's a lot more legitimacy right now, or a lot more logic in explaining to the class what conventional X-ray looks like and how it can be used. Because what I do with the fluoroscopy is at a level that isn't very mainstream, and is not there's not a lot of utilization of it, even though it's extremely valuable in diagnosing injuries properly. Okay, so we'll go on to the outline here. I'm just going to do one thing. There we go. All right, so the 5 parts for today I'd like to go over, and that is the first part being an overview of the bony anatomy of the cervical spine. A lot of this should be a review for you. The second part is an overview of the most common imaging methods used to evaluate the cervical spine. So not just X-ray, I'll show you the 3 main kinds. And hopefully some of you will be able to notice the difference before I explain that which one is which. Overview of the 3 basic views of an X-ray for evaluating the cervical spine. And I say 3 basic because there are multiple more views that can be taken, and sometimes do get taken, for better assessing 3-dimensional structure like the neck from various more planes than just the 2 planes that are generally evaluated. And then the X-ray, I'll show a bunch of X-rays, or a few X-rays of the cervical spine, and comparing what would be deemed normal or expected for asymptomatic people, and comparing that to not so normal. And these will be subtleties that are seen a lot, but are not often found relevant enough to put into motion anything of therapeutic desire. And then the last part, like I said, I'll show you how a motion X-ray of the cervical spine is different from a standard X-ray, outside of just that the colors are reversed, but the fact that you can actually do movement and it's not blurry. It doesn't get blurry like a regular X-ray does. Okay. So the first part here, again, should be hopefully a review, overview of the bony anatomy of the cervical spine. We've got 3 views. We've got, so the lateral view, so looking at the cervical spine from the side. On top here, at the very top of the picture, that would be where the head would sit. Then we've got 7 cervical vertebrae, starting with the atlas, or C1, the axis C2, and then we have the 3rd, 4th, 5th, 6th, and 7th are all labeled accordingly because they're cervical spine, so they have the letter C, and then 1, 2, 3, 4, 5, 6, 7. The discs start between C2 and C3, so up at the top here between the skull and C1, between C1 and C2, there are no discs. And so the discs starting at C2, 3 and working their way down throughout technically the rest of the spine, not just the neck, are starting there. And then we have the spinous processes in the back, so on the right side of the screen here. So, and C1 doesn't have a spinous process, it's got a posterior arch. And since C2 has a spinous, 3, 4, 5, 6, and 7 all have spinous processes. And then the entire cervical spine has this side foramen or opening here that allows the vertebral artery to go through there. partially to protect it, but also when degenerative changes happen, that fact that it traverses through the actual cervical vertebrae could encumber the vertebral artery and cause vascular issues from a mild to a much more severe manifestation. So that's the side view. This is a view from the...
Sorry,
yeah.
We're only seeing the anterior posterior view, like slide 15 by the looks of it.
So you don't see the side one here?
No.
What do you see now?
I think the screen's frozen or something.
Okay. Bear with me for a sec here. I think I figured it out, and I apologize. Can you see it now?
Yes, there we go.
Yeah, I was just sharing my PowerPoint instead of sharing my screen. I have like 15 options on there.
That's okay. Okay, we're good to go.
So the slides that I'm just going to go back to right now, you did not see before? Are these looking familiar at all or no?
No, we saw none of those.
Okay, well, that's fine, because this is kind of irrelevant. I'll get to where I was at right now, which is actually pictures. So here's the lateral view. Can you see that now?
Yes.
Okay, I apologize.
That's okay.
Jump in if this goes south again, just jump in right away. So again, this is the lateral view. At the very top here is C1 or the atlas, and below that is C2, the axis, and then the rest of them are named, like I said, C3, 4, 5, 6, 7. The atlas at the very top does not have a spinous process. It's got a posterior arch. C2 has a spinous process, which has the largest bifid structure, and the C3 spinous 4, 5, 6, 7. And along the lateral aspect here, the side aspect, those are the openings where the vertebral artery goes through, and just to the right of all those are the openings where the nerves exit. And so you'll see this a little bit more clearly on a top view when I show it in a minute. And then, like I said, the discs start at C2, 3, and then work their way throughout the rest of the spine. But the very top of the neck, including the skull, there are no discs. And so here's the front view. You can see the anterior view now?
Yeah.
Okay, wonderful. So again, 7 bones. You can see how very different the atlas looks up on top there. And then we have the axis below that. And the axis does have a tooth-like appendage, or the dens, that goes right inside the atlas. And then again, here's where the discs start. And the shape of the cervical vertebrae are smiley faced. So the discs have a really difficult time herniating sideways. They'll either herniate forward or herniate backwards because of these raised lips or these uncinate processes that the cervical spine has. So again, discs would be, they don't show the disc on this particular, this is just bony anatomy on this particular image, but the disc would be here. There would be a disc between 3 and 4, a disc 4 and 5, a disc between 5 and 6, and a disc between 6 and 7. And if we go on to the posterior view, so this is a view from in behind. Here you can see the spinous processes, and you can see that dens that I was talking about a second ago from C2 that sits inside of the atlas. And so basically the atlas revolves around the axis, and then the head sits up on top of these 2 blue concave pits, okay? We have facet joints. There's a term you've probably heard as well, and the facet joints are not the same as, if I go back, the front disc joint. So there's a disc in between the vertebral bodies, and then in behind there are facets on the left and the right side of each 2 paired bones. And that's where the majority of motion happens, is in the facet joints. And they're encapsulated with multiple ligaments that cover each other like paper mache around the joint. And then that's what we call then a capsule, which is not depicted on this image here. Now, the 2 unique bones in the neck, as I've sort of alluded to a little bit, are the atlas and the axis. So the atlas has no body. What substitutes for the body is the dens from the axis, and that allows for the greatest amount of motion in any 2 segments within the entire spine. And so the atlantoaxial joints are by far the most mobile in an uninjured individual. And in my line of work, this particular spot ends up being the missing link in most cases where the patient is not able to find answers anywhere as far as diagnostics, is that the atlantoaxial joint being injured, or joints being injured, lead to hypermobility and or instability, causing lots of dysfunction and lots of pain and problems here that not only affect as far as pain situation, but also affect the central nervous system, because just in behind here is where the last part of the brainstem sits, which is the medulla oblongata and the first part of the cervical spinal cord. So if that gets compressed because these bones are moving too much, you can have all sorts of neurological complications. And again, the C1 is named the atlas, the C2 is named the axis. The other ones don't have any fancy names. And then this is another depiction of the atlas and the axis. So on the left image here, this is a view from above of the atlas. So the skull would sit up on top here. We have the posterior arch, so there's no spinous process, especially when you compare that to C2 that has this bifid, which means it's A-framed spinous process. That means that tissue is attached from the left and tissue is attached from the right to that. That's why there's two. And the dens sits right inside here, and there's this little notch in the anterior arch of the atlas where the dens sits in. And then, like I showed in the last picture, it's got this strandy black thing going around, and that's a ligament that basically keeps the dens inside here and pasted up against this little notch so that it doesn't migrate backwards into that opening, which would then logically compress the brainstem. And then on the right side picture here, you can see this opening here in the atlas and this opening here in the atlas. These are called transverse foramen or transverse foramen. Every single cervical, oops, sorry about that. Shouldn't have a touch screen. I forgot I had a touch screen. Each one of the cervical vertebrae has a transverse foramen on the left and on the right side. And that's what then houses the vertebral artery. And you can see the difference between, for example, the atlas and the axis, which technically doesn't have a body, but it slightly does, but it has this dens or this projection of this tooth. And then you get, and it's got large facets, and then you get to something like C5. So we decided to take something mid-neck, and you can see the size of the body here, and also got a bifid spinous process. But again, C2's got the biggest bifid spinous process. And then these transverse foramen as well that then house the vertebral arteries. Okay. So then we'll look at an overview, and I wish I was kind of there right now just to be able to have a show of hands, but we can do that anyways as a little bit of an experiment. There's the three different modalities, and if with a show of hands, I can kind of see you there. Who thinks that the image labeled 1 is an X-ray? Who thinks number 2 is an X-ray?
No, it's number 3.
Okay, who thinks number 3 is an X-ray?
There you go.
Awesome. Who knows what number 2 is? Anyone? You can yell it out. Yep. And number 1? What's the consensus on number 1?
Ultrasound?
Nope.
CT.
It's a CT scan. Yep. It's a CT scan. This would be one version of a CT scan. CT scans have bone windows and soft tissue windows, and then the middle one is a MRI. This better known as a T2 weighted image, which shows water as bright white. So the cerebral spinal fluid is white and the spinal cord is black. And then obviously this is a lateral view of a cervical X-ray. Okay, so by far the most common means of assessing the cervical spine is by way of X-ray. And then I would say number 2 and 3, or so CT and MRI are kind of scattered as far as their utility, probably 50-50 there. I wouldn't say that I've seen any preference for one of those over the other, even though I have a preference with one over the other. And that's simply based on the level of radiation. I would pick an MRI over a CT scan any day, unless I was trying to determine whether or not the person had a bony anomaly, which means some kind of a potential birth defect that is specific to the bone and not so much the soft tissue, where the MRI would have a tough time picking it up, not because it can't pick it up, but because the contrast between bone and soft tissue is not so sharp as it is with CT scan. So that's kind of a off tangent there, but I thought it was valuable to note. What's interesting is I pulled this MRI image off Google, and it was labeled as a normal MRI scan. However, there's a bulge here at 2, 3, 4, 5, between 6 and 7, and there's also facet hypertrophy on the back. So this person has a narrowing of their canal right at C6, C7 right here, but yet it's labeled as a normal MRI by Google. Okay, so overview of the three basic views of taking an X-ray of the cervical spine. Again, there are many more views, and some of them are positional, and some of them are just angled at 45 degrees. But basically, what I want to review here, because this is simply the basics, and this can be elaborated upon, is the three views that are most common and should be standard protocol as a bare minimum anywhere X-rays are done of the neck. And I actually do see the number 3 omitted regularly, unfortunately. And I'm not quite sure as to why that is, but we have a lateral, so a side projection of the neck, and then there's an anteroposterior, or what would be then called an AP view, if you ever see that on an X-ray report. And then we have an anteroposterior open mouth, which is an APOM. And AP just simply means that the X-ray beam is coming from the front of the patient through the back of them. So the direction is anterior to posterior of the X-ray beam. You can flip a person around and call it a PA, which then changes the orientation of things and changes what gets magnified and what doesn't. But then it would be called a PA, posterior-anterior. Does that make sense?
Yep.
So we'll start with the lateral view. Again, you've already seen that. So this is what would basically could easily be deemed as a normal lateral view or side view of the cervical spine. Again, 7 vertebrae. You've got the skull. Then we've got vertebrae 1, the atlas axis, 3, 4, 5, 6, 7. And the goal is to get all 7 of those on the actual film without any encumbrance. So sometimes a person's got broad shoulders and they'll go up like this. And for that, this is another one of those obscure additional views that they could do. They could get them to move their arms out in front, one arm out back, and they call that a swimmer's view, which then gets the shoulders out of the way so that the denseness of the shoulders is no longer in the way of imaging C7. But for this particular X-ray, C7 is pretty well visualized, except I would say the spinous process is kind of overexposed, if you will, or underexposed, I guess. Okay, does that make sense? You can see how clear you can see all these other spinous processes until you get to C7. There's a lot of white there.
Mhm.
Does that make sense?
Yes.
Okay, and then we've got the anteroposterior view. So this is a lot harder to look at because there's a lot of overlap tissue. We've got the discs and the uncinate processes, and then in behind that, we've got the spinal cord, and then in behind that, there's the spinous processes, and then there's the facet joints on the sides. So there's a lot of overlap of tissue that you don't have as much of when you're looking at a side projection, because the anteroposterior has the beam technically coming from the front. So where this R is coming from there and it's going to the right. So it's got to go through the front part of the body, the back part of the body, and the rest of the body, then go through a facet joint, then go through the spinous process and out the back through the skin and the muscle. So there's a lot more things to penetrate, whereas from the side, it's literally the side of the vertebra and then the discs in between the vertebra, and then it goes out the other side so we can see the spacing much more nicely. And the way the facets are oriented, we can see them much better as well on this lateral view. Okay, so back to the AP. If there are any burning questions as we go along, feel free to shoot. And otherwise, I'll leave time at the end for questions as well, okay? So this is the AP, and then this is the APOM. So this one is labeled, but it's beneficial that it is labeled because there's a lot to see here. This is by far the most important view for somebody coming in with a cervical spine injury or a suspected cervical spine injury. And this is why I said it blows my mind that this particular view I've seen omitted somewhat too frequently in the last few years. And I don't quite understand why that would be. But so to give you an outline, so the axis, which is C2, starts, if you can see the arrow here, starts, it goes up at an angle. There's a little bit of a notch and it goes up into the dens, which is this, the tooth-like structure on C2, comes back down. There's a little bit of a notch and then it goes down at about a 30-degree angle off. On the side of that, this right here is the lateral mass of C1 on this particular person's, this would be the left side. That's how they take x-rays. And you can see the R down here indicating that this is the right. Generally, when you look at x-rays, whatever's on the right side of the screen is the left side of the body, and what's on the left side of the screen is the right side of the body. It's like you're looking at someone instead of looking in the mirror. And then on the other side here, again, this is the other lateral mass belonging to C1. And then there's a dark space in between those two on either side, and those are relatively equal or should be relatively equal. The dens, if this person's head is not rotated when you take the x-ray, and assuming that their teeth are midline on their face, that they've been properly set on their face, you will see a split between their central incisors, or their two front teeth basically, And that should split right down the middle of the dens in a perfectly taken x-ray without the patient's head being slightly rotated or off center. So it looks like the dens is cracked down the middle, but it's not. That's just the split between the two front teeth. And then we get down here, and there's that A-frame I was telling you about, that bifid spinous process that belongs to C2, which is an important structure, again, for looking at, when looking at imaging without these words embedded on there showing what the anatomy is. And then there's a side edge to the lateral mass that drops down, which should line up with the side edge of the side of C2 on either side. The wording gets in the way here, but these two are lined up as well. So, and that's kind of the gist of the majority of things that one should see in there. And the relative space between the outside of the lateral mass to the jawline should be relatively equal on both sides. And in this case, I would say maybe this side is slightly bigger, but very minimal based on the other landmarks that I just explained. And this large white mass right here, these are the upper molars on this person's right. And this large white mass are their upper molars on their left. And because, as you see in the lower jaw here, that tooth line curves around like a horseshoe, the reason why this looks very white is because you're looking at some of these teeth on end. Some of them you see face on, and other ones are stacked in behind the other ones, so they look very blurry and thick. Does that make sense? So this is the anterior posterior open mouth, or as we call it, the APOM. And then we have the AP, which, as you can see here, it actually doesn't, when the mouth is closed, you actually do not see C1 and C2. So if I count from down here, these appendages going up belong to T1. So that by default makes this C7, C6, C5, C4, C3, and then C2 and 1 are up in here and behind the jaw. And that's where the benefit of doing this open mouth one comes, that you can actually see those top two bones at least somewhat sufficiently by way of opening the mouth, okay? And if I go back to the lateral view, it'll make a little bit more sense as well. This is the jaw right here, the teeth. So you've got the beam coming from where the where the R is here, coming through the jaw, trying to get through C1 and C2, again, with all the density of the anterior portions of it, the posterior portions of it, and then out through the muscles in the back. You get a lot of black, as you see in this, or sorry, a lot of white, just a lot of denseness. And so that's why we do the open mouth. Okay, make sense? And then, so I'll show you the normal again, and then not so normal, and maybe by, again, a show of hands, or if anybody's got a particular answer to what would be the not so normal in the image that's not the normal one, please go ahead and either shout it out or put your hand up, and Alicia can tackle that. So we've got on the left side of this picture is the normal, like we had before, and on the right side is the not so normal. And outside of the fact that this person is still wearing their earrings, which should have been removed for the X-ray, who can tell me what is? And you can see how jewelry or metal objects can get in the way of the anatomy, and that's why it's pertinent to remove all that stuff if possible. Sometimes earrings are not able to be taken out, at least not very easily, and so we will by default, let them keep them in unless it really gets in the way. But what other than the earrings, can anybody tell me looks not so normal on this right-sided image?
Yes, hypolordosis.
Exactly. That's one of the most important things that doesn't get enough attention on a regular basis, even when I deal with this in clinical practice. This is actually a reverse lordosis. So this would be a cervical kyphosis. So this, again, being the back of the neck on this normal picture, the cervical spine should be concave posteriorly and convex anteriorly. And in this case, this person's is concave anteriorly and convex posteriorly, with the vast majority of that happening here at C2, 3, C3. You can see how C2 kinks to the left. And then the rest of it is pretty straight, but the kyphosis happens in the upper cervical spine. Okay, so yes, a reverse lordosis is one of the most important findings when looking at a cervical spine X-ray, because that'll tell you that this person has had whiplash, 100%, and that their muscles have been undergoing some level of splinting for whatever amount of time from that whiplash to the point that they might be seeing you for a massage. And therefore, doing something that would accentuate the lordosis in a mild way while treating them will actually be very, very blissful for them. Okay, so this is the lateral projection, and this is the AP projection now. So on the left side, again, we've got the normal, and on the right side, we've got the not so normal. Can anybody see what would be obvious here?
Tilted head.
Absolutely, yeah. Do you think it's kind of curious to know that this kind of stuff doesn't make its way into reports when I read reports?
Really?
Seems pretty logical as far as I'm concerned.
Mhm.
And then, so then we'll get on to the APOM. So on the left side, you've already seen the normal, and can you tell me what would be unusual or not so normal on the right-hand picture? Anyone?
Dens is tilted, they're saying?
There's arrows pointing to the spaces.
Yeah. Oh, yeah.
So this is one of those things, because I showed you on the left-hand picture that the middle of the incisors splits the difference on the dens, so it should literally go kind of down the middle of it. That will tell you that the head is probably not rotated because the two front teeth are not in the same space as the dens is. The dens is probably 4 or 5 inches posterior to the teeth. And so if your head is rotated even slightly, your teeth will not line up with the dens. And the same thing with the dens itself. The dens, or the C2 itself, the dens is about, I would say, 1.5 inches, 2 inches from the C2 spinous process. And so even if just C2 is rotated, the dens and the A-frame won't line up. But in this case, what you see is the two incisors, and the split between the two incisors literally splits the difference between the dens. And then you go down and you've got the A-frame is also dead center of all that. So C2 is not rotated, the head is not rotated, but what we're seeing is a decreased gap here between the dens and the lateral mass on this picture's left side. And then we're seeing probably it's about 3 to 4 times the size here on the picture's right side. Can you all see that?
Yep.
And again, this is commonly, if at all ever, commented on in a radiological report. This would be not even commented on, let alone as this is possibly a significant finding and maybe the patient wasn't positioned properly. So that doesn't even generally make its way into reports, but this is what I come across on a very regular basis. And the other thing with this, when I talked about the side margins of C1 and C2 lining up, you can see that there's an overhang right here. So this lateral mass overhangs the side part of C2. Do you see that right here?
Yeah.
They're not lined up in verticality. So this is the side edge of C2. That means the side edge of C1 should be just above that, but it's all the way over here. Can you see that now?
Yes.
So this is an absolute, in my experience over the last 20 years, an absolute suspicion for upper cervical ligament damage, which would then predicate this person being strongly qualified to undergo motion X-ray. And I'll show you at the end. Like I said, it's a teaser because this is just supposed to be conventional X-ray lecture. But at the end, I'll show you a teaser of how a motion X-ray picks up on things that a static X-ray will never be able to do. You can just get little hints and tip-offs that would tell you there's probably something wrong. But with the motion X-ray, you can actually see it happen in real time. Okay, so let's move on. Any questions on that so far? Clear as mud?
There's mine.
Okay. Okay, so I'm reaching the end of the lecture here anyway. So I just wanted to sort of, like I said, give you a teaser and show you how a motion X-ray of the cervical spine differs from a standard X-ray. And so I'm going to show you a lateral view of a motion X-ray, and I'll play it's actually a video, so there's no static image here. So once I press play, it's going to play the video, and then you'll be able to see what can be visualized when you take this person's anatomy out of neutral position and have them go through their natural range of motion, in this case, the sagittal plane, and then how that can give you much more information that is relevant to how you would treat them or potentially refer them for a neurosurgical evaluation based on this knowledge, okay? So like I said, the colors are reversed. So what was black on the regular X-ray is white here, and what was white on the other X-ray, a regular X-ray, is black here. So the colors are reversed for fluoroscopy, but in doing so, you're able to actually allow for movement without blur, okay? And so again, so this is very similar side projection. There's the person's jaw, back of their head is up here. This is C1, C2, C3, C4, C5, C6, C7. And what's important to look at, and I'll tell you where to look, and then you can basically focus on there. But if you look at the junction of the skull and C1 and C2, watch what happens when this person goes into movement. And this sort of ties in when someone's telling you if in the future in clinical practice, every time I'm down looking at my phone and texting, I get lightheaded or something like that, or every time I'm looking up, I get a little bit dizzy. they're not subtle hints. Those are hints that should be taken very seriously, especially if they mention it repeatedly, because when I show you this, it'll make a little bit more sense. Okay, so I'm going to hit that play and you can watch. Did that come through okay?
Yeah.
Yeah.
Any questions on that one? Did everybody see that?
Yeah.
So we basically have the atlas dislocating off of the axis. And that's not a normal finding. So in this case, this type of a patient is a stat referral to a neurosurgeon that will hopefully take this seriously and bolt those two bones together. This is not a chiropractic or a massage patient. Okay. And there are people like that walking around. I've had no shortage of people that I've done a motion X-ray on that have shown these types of findings. Do you want me to play it again?
Yes, please. That's crazy.
So you know what's holding this person's C1 and head from dislocating off of C2? The medulla oblongata.
Oh my God.
And so when this person says, I'm peeing myself, I'm falling, I'm basically having drop attacks, I faint without even realizing I'm going to faint. I'm nauseous all the time. I have blurry vision. My heart's beating out of the chest. I'm constantly sweating or have cold chills. That's all vagus nerve related stuff. Okay. Can anybody tell what that's an X-ray of? That's called a X-ray photobomb.
Yeah.
Somebody's having a chest X-ray and somebody decided to go, hello. All right. Any questions? I know that was pretty basic, but hopefully it wasn't too complicated for anybody. And but yeah, so those are the basics. And there's a lot more complexity to just X-rays, let alone getting into MRI or CT scan and different variations of MRI and CT scan that were intended to evaluate particular suspected pathologies in the neck and or brain. And so yeah, any questions?
Yep.
Is it a lack of training that people are saying what he's saying?
A lack of training
Yeah, what he's finding.
for what you're finding.
Say the question.
Is it a lack of training for what you're finding?
What why other
They don't find it.
Why are others health professionals not finding
Yeah.
Oh,
this?
Okay, so yeah, so I guess the biggest answer, the most concise answer to that is that most medical professionals outside of surgical specialists, so orthopedic surgeons, neurosurgeons, they generally do not have training in radiology, nor do they have a active desire to look at imaging, and so they base their clinical decisions off of radiology reports. And why radiologists don't note these things down is because the criteria for looking at imaging of certain body parts does not include what I just explained. And so occasionally I will see a radiologist make comments to that the paraodontoid spaces don't look congruent, and if there's a suspicion of a Jefferson's fracture, which is literally when someone dives into a pool without water and they basically their head cracks down, it puts so much force on C1 that C1 bursts open, and then you have a fracture of the anterior and posterior arch and sometimes the lateral masses. That is considered a surgical problem, and so that's often when you see altered paraodontoid spaces, but oftentimes they won't even comment on those paraodontoid spaces being incongruent, and it's simply because it's not part of the criteria for looking at the X-ray. And if they do comment on it, they'll probably, like I said, comment on something to the notion of potential patient positioning error. And like I just explained, you can use other landmarks to determine whether that is logical, that the patient's head is rotated and it was a poorly taken X-ray, or if it actually was a decently taken X-ray and that is a significant finding. And the other thing is when you have a Jefferson fracture, in most cases you have a whole overhang on both sides, so both periodontoid spaces are increased. But with ligament injury, which is not it's not taught at all actually in any of the specialties. So ligament injury and how that affects the craniocervical junction is not something that is taught at all. The vast majority of medical professionals, myself included, until I started getting interested in this because of my own cervical spine injuries, is that the notion of an alar ligament and a transverse ligament is very foreign to most medical professionals. Like, I mean, I'd be hard pressed, even back when before I started, getting interested in this and studying this about 20 years ago, I had no idea. I'd heard of an alar ligament. I had no idea what its attachment points were. I didn't know that the transverse ligament had a superior and an inferior band, and that's why they call it the cruciate ligament. So all these things that are of relevance, but are not mainstream. And I think the reason they're not mainstream is that they're still to become mainstream at some point in time. Most of the things that I find in clinical practice, even the stuff that I was taught, is probably at least 3 decades outdated compared to what current research knowledge is discovering. And so unless I'm actively looking at current literature publications, I'm outdated.
Sure.
And as far as, like I said, the medical doctors and other non-surgical specialists, they rely on the radiologists to build a concise report that they base all their decisions off from that point on. And for myself, I will get the report, but I will always request the imaging so I can vet it for myself. I will not treat patients if I have not vetted the imaging, if there's imaging available. Simply because of these findings, because if I didn't notice the static suspicion and then follow that up with a motion X-ray, the patient is a ticking time bomb, and it's a strong contraindication for me to be doing some of the things that I would normally do on a patient that doesn't have that injury. And the only way to discover that is by imaging, and definitely not by going off of the reports, because the reports don't pay attention to these things. Okay.
Good question. Anybody else? What are the potential treatments for those conditions?
Well, for this particular condition that I showed you with the video or the motion X-ray, that's a surgical intervention. So C1 and C2 need to be fused together by surgical fusion, so with screws. Somebody who doesn't have that severe of an instability, generally neuromuscular techniques such as acupressure, trigger point techniques, some ART, but again, you got to be very cautious of the motion that you perform by way of doing ART type techniques, because if they do have some level of instability and you're doing motion in that direction, you could be helping their muscles while at the same time irritating their brainstem and spinal cord. And that's why I always divert to acupressure or trigger points, or what technically is termed a pneumoreceptor tonus, which is the official name of the technique that I use.
Yep.
Or if you're like born with this structural reverse lordosis, is it okay to be living that way, or do you have to like do any like intervention for that?
I didn't catch that.
If you were born with a structural issue with the hypolordosis or the kyphosis in the neck, is there, what was the question after
Wait,
that?
so like,
Is it okay to live like that, or do you have to do something?
There's a lot of people that are living like that. And in my clinical experience of 22 plus years, I've never seen a congenital cervical kyphosis. It's always post-traumatic.
Okay. Yep. Is there any efforts to modernize your, sorry, what was it?
To modernize or promote what he's finding in the other field?
Or promote what you're finding to the other fields?
Just patient by patient, there is efforts. And I mean, the efforts have been going on for about 10 years now, and it is gaining traction, and it is gaining interest from the specialty fields, because it is logical. I mean, just because it's something that they weren't taught, nor was I found a personal interest in this and then went on a tangent and lo and behold, here we are. But just because it's something they're not taught in medical school or as a specialty within neurosurgery or orthopedics, it doesn't mean it's not credible. And I've shared many lectures with specialists where I've actually pointed out to them that video fluoroscopy for the utility of diagnosing aberrant excessive motion in the cervical spine, and then moreover assessing the integrity of surgical hardware if there's a suspicion that implanted hardware in the neck was coming loose after some amount of time, which would then be failed hardware where they have to go in and fix that. That video fluoroscopy has been used for that and been put in literature as the go-to for that kind of stuff since 1966. And that was an article published in the Journal of the American Medical Association, so quite a reputable publication in JAMA, dating back to 1966, where they literally, and these were medical doctors that published that, not chiropractors or anybody from the alternative side, that published that as a strong, the go-to, the number one type of thing you want to do if you want to assess the lack of integrity of the cervical spine. So if it's been messed up, basically. But it is gaining traction, and it's day by day.
And you said, are you the only whiplash clinic other than the one down where you are right now?
Yeah, that's just the name of the clinic. So we basically specialize in head and neck trauma, but everything under the sun as well, as far as spine and joints are related. But we're the only clinic in Western Canada that has a motion X-ray machine. And we're also the only clinic in the greater, I guess if you want to call it, Seattle area that has the same thing as well. So people from all over the country and even all over the world will come into Langley or Linden for this particular imaging and getting assessed to see whether or not they have permanent ligament damage and instability causing brainstem compression and the whole gamut of neurological complications that they've possibly been living with for years to decades.
And do you see different severities, or do you see like more severe cases?
No, there's a difference in severities. Absolutely, yeah. And but the vast majority are people who are all having very common neurological problems that are akin to all of us. And so there's definitely a demographic, and those people are generally the ones that have been labeled with post-concussive syndrome or permanent post-concussive syndrome, or even fibromyalgia is a big one. Then there's chronic fatigue syndrome, myalgic encephalomyelitis, Pott's disease, dysautonomia. So all of these named conditions all describe symptoms, and all those symptoms literally correlate to what one would expect to happen if your brainstem was being irritated, whether mechanically or by some kind of metabolic process. But in this case, it's pure mechanical compression in these cases when they have instability, because the bones shift too much, and when the bones shift too much, they bump up against the brainstem, and you have autonomic nervous system dysfunction as a result of that.
Yes.
What you just said, would it be a recommended course of action for people with fibromyalgia to get X-rays like that?
Would it be a recommended course of action for people to get X-rays with fibromyalgia?
Yes and no. I would first want to make sure that they also have, blood pressure issues, heart rate issues, temperature control issues, digestive issues, vision issues, so blurry vision, ringing in their ears, fullness in their ears. If they have that kind of stuff, that's telling you that it's more of an autonomic, in addition to what's been labeled as, because fibromyalgia is ultimately fatigue and sore muscles, right?
Yeah.
And so if they have all these other things that are more neurological based, then I would say absolutely, because they may have just been mislabeled with fibromyalgia and nobody's really paid attention to the nausea, to the dizziness, to the balance and coordination issues, short-term memory loss, temperature control issues, blood pressure. I already said that, heart rate. So if they have all those things as well, then absolutely.
Interesting.
It's just that some of the time the problem is in the level of questioning that gets brought to them, that enough information is not drawn out of them, which is there. So then an assumption is made that it's possibly not there, or there's not even a desire to even ask for it, or the knowledge that it would be relevant if asked for it. And so definitely there's a link to that. So long as the relevant questions are asked and they have those symptoms, then absolutely, yeah.
Any other questions? You know.
No other questions?
No.
Awesome. My contact information is on there. That's probably the easiest email. Or you can just run through the contact form on either drblaskovich.com or whiplashclinic.com. And then the phone number is there as well for the clinic if ever need be. And yeah, thanks for having me.
Thank you for speaking with us.
Thank you.
My pleasure. So I don't know how to, there we go.